hyperparathyroidism is a common condition. It can be very difficult to diagnose and difficult to follow up, particularly in the setting of primary care. My name is Neil Gittoes. I'm a consultant and honorary professor of endocrinology, and I'm clinical lead for the NICE guideline looking at primary hyperparathyroidism. Guidelines for primary hyperparathyroidism are important because there's quite a significant variation in practice from person to person, from clinician to clinician, and there's problems around the diagnosis, identifying the condition and knowing when surgery may be required. The presentation is with raised serum calcium levels, and this is due to one of the 4 parathyroid glands that sit at the back of the thyroid gland becoming enlarged. Very rarely more than one gland can become enlarged, and the only definitive way of getting rid of the problem is with successful surgery to remove the adenoma. Primary hyperparathyroidism often presents these days as a coincidental blood test finding of a raised blood calcium. You can imagine the scenario, you have your blood test, your calcium's high just because you've had your cholesterol checked, and then somebody says to you, "So how have you been feeling then? A bit off colour, a bit tired, a bit achy?" So it's that thing that often secondarily, when somebody tells you there's something not quite right in your biochemistry, but as a presentation, it's a can of worms, it really is. Do we screen everybody who's feeling a bit off colour? If you keep coming back not feeling quite right, we say, we'll check your calcium, it's cheap and cheerful, there's no harm in doing it. Patients may have thirst, getting up at the night and passing lots of urine, and constipation. Those are some very clear features of a raised calcium. So it's always worthwhile repeating calcium more than once. Calcium measurement is tricky because it tends to be reported as a total calcium and an adjusted calcium, where we adjust for the albumin. The one to pay attention to is the adjusted calcium. And if on 2 occasions it's elevated, then your next key step is to measure PTH. PTH is your best friend. If the PTH is suppressed, and I would put that at the top of my list, you should be thinking about a diagnosis other than primary hyperparathyroidism. And within that list could potentially be malignant pathologies, so you really need to pay attention to that. If the PTH is not suppressed, then pretty much you're in the territory of making referral into secondary care. Particularly if the PTH is above the midpoint of the reference range, the probability is that you're looking at a diagnosis of primary hyperparathyroidism. So patients often ask me, because I've got this calcium problem, do I need to change the amount of calcium that I eat? And the answer is no. A healthy, balanced diet, something that is absolutely mainstream, is the right thing to do. Don't try to restrict your calcium, don't try to take in more. Take your vitamin D if that's what you've been given as a supplement, but just have a normal diet. So once the diagnosis of primary hyperparathyroidism has been made, then referral into a secondary care environment is helpful. And then the key question is making sure that you've got the right diagnosis, and then to determine whether a curative procedure with parathyroid surgery should be employed or not. Emergency treatment in primary hyperparathyroidism is pretty unusual. Occasionally patients may present with extremely raised calcium, particularly if they become dehydrated. That is unusual, and occasionally we perform early parathyroid surgery. But importantly, don't just look at the numbers. If a calcium is 3.0, for instance, and the patient is very well and they've got primary hyperparathyroidism, there's no requirement for emergency admission. Initial steps in secondary care once the patient's been presented with query primary hyperparathyroidism is to confirm the diagnosis and to look at the way in which the kidneys handle the calcium, so looking at urine calcium excretion. And we'd expect that to be either high or well within the reference range. Okay, so once in a secondary care environment and using all the investigations that we've mentioned to date, the next question is, do we think this patient would benefit from surgical intervention? If we think surgery is a reasonable way forward, then we perform some imaging investigations, starting with ultrasound, because it's quick and easy and no radiation involved. In addition to that, we check renal function as well, and then we'd look for end organ disease, in other words, any long-term consequences of primary hyperparathyroidism, and that would be done conventionally by using ultrasound of the kidneys to look for stones, and using DEXA scan to look at bone density to see if there's a particularly increased risk of fracture. Okay, so once the patient is referred to a surgeon, and the surgeon will have a discussion that will take into account the imaging results that have been obtained. And then either a focused approach, where there is a more targeted surgical approach to the adenoma, if there is a single adenoma. However, if things are a little more complex, or if it's difficult to identify the adenoma, then an open approach with a slightly longer scar to examine all 4 glands would be performed. Procedure may be done same day or overnight stay in some settings, We often say that really recovery, perhaps 2 to 4 weeks before patients should be doing too much following successful surgery. So immediately after parathyroid surgery we would check the calcium level, and the PTH levels fall quickly, so the calcium falls quickly, so we know pretty much straight away whether parathyroid surgery has been successful. And what I would do in my role would be to see patients 3 to 6 months post-surgery as well, and that's what we use as a definitive, if you like, cure point, checking the calcium at that point, looking for any evidence. Do we need to do any more about underlying bone disease? Are there stones that need to be managed? So that's then a separate issue, more getting into the longer term management. So if the patient hasn't gone forward for parathyroid surgery with a diagnosis of primary hyperparathyroidism, it doesn't mean that at any point in the future they may not be a candidate for surgery. So keeping an open mind is important, and monitoring as well. So checking the blood calcium and kidney function on at least an annual basis is important, or in between times if the patient is unwell also. Keeping an eye on bone density and fracture risk with DEXA scan every 2 or 3 years, and if you're concerned that a renal stone may be brewing, then an ultrasound of kidneys is important as well. There's a subgroup of patients where perhaps parathyroid surgery isn't feasible and their calcium level may be high to the extent that we would think about introducing a drug, a calcium-mimetic drug called cinacalcet, but that tends to sit very much in the realms of secondary or tertiary care. Primary hyperparathyroidism and pregnancy is difficult and simple all in one, and my simple advice would be, if you have a patient with primary hyperparathyroidism who is pregnant, refer to the MDT, to the specialist MDT. This is rare and difficult and needs to be managed on an individual case basis. So within the NICE guideline, I think some of the key points that we've tried to highlight is around the importance of measuring the calcium on more than one occasion. Really important if you've got sustained hypercalcemia to measure the PTH, and remember, if that PTH is suppressed, to think about an alternative diagnosis. But to refer those patients up who have PTH well within the reference range to be considered for potential parathyroid surgery. So the guidelines were developed, the guideline group incorporated GPs, specialists, surgeons and patients. So having that open dialogue and communication with patients, and as well linking back to what we can offer with long-term management of these patients with shared care, keeping communication open as well between primary and secondary care, so that we're all speaking the same language for what can be a chronic disease if we don't cure it at the time of surgery. The evidence and the data around this rather complex area are not full and not complete, so there's a lot of pragmatism, and we spend a lot of time making these clinically useful as much as we can. So the idea of these guidelines are to be very much user-friendly, to be used in the field so that you can channel patients and determine which points they should be referred into the system. But as I say, this is a very clinically focused, hopefully clinically useful tool that's meant to be used on a day-to-day basis, because at the end of it, this is a really very common presentation.